Okay, so welcome everybody. We might just get started. People will be coming in over the next 10-15 minutes anyway. Welcome, and we're delighted to have you here. So this is a webinar that's going to be around the theme of patient safety. And that's because, as we all know, last week was World Patient Safety Day on the 17th of September. So just very quickly before we start, most of you already know about ISQua. But just for those of you who don't, ISQua is a member-based, not-for-profit community organisation dedicated to promoting quality improvement in healthcare. So we're a global organisation. We have a presence in about 90 different countries now. We have been working to improve quality and safety of healthcare worldwide for over 30 years, and we aim to achieve our goal through education, knowledge sharing, external evaluation, and supporting health systems worldwide. We also want to connect like-minded people through our healthcare networks. Excuse me. So this webinar is part of our knowledge stream. So we're very excited to have a number of speakers here today. We have an agenda, which is first of all just me talking. We're going to have a panel discussion. And that'll be for about an hour on the mental health of workers, the concept of the second victim, and workplace bullying. So how do these things affect patient safety? And then after that, we're going to have a discussion about opportunities about quality and safety improvement and how we can get started. So I just want to quickly introduce our speakers. So we have Dr. Zainab Yunusa-Kaltungo. She is a consultant plastic surgeon and former patient safety lead at the Federal Teaching Hospital in Gombe, Nigeria. We also have Dr. Gbonjubola Abiri, consultant psychiatrist and medical director of Tranquil and Quest Behavioural Health. Sorry, I'll try that one again. Consultant psychiatrist and medical director at Tranquil and Quest Behavioural Health. And also we have Chika Odioemene. She is a nurse, registered nurse, and CEO and founder of Utopian Healthcare. So we're delighted to have you all here. And we also have a number of other panelists. So we have Stephen Balogun, who is one of our ISQua ambassadors. We have Emmanuel Aiyenigba, who is our first ISQua emerging leader. I think that was in 2017. We have Rita Okonkwo, who is our current ISQua emerging leader. We have Kendra. I'm not sure if Kendra's here yet, is she? And we have Achama Eluwa, who is also an ISQua fellow. So delighted to have you here, as I say. We might just hand over now for the panel discussion. So Rita, I think you're going to be coordinating this. Am I right?
Yes.
Yeah, great, okay. Lovely.
Enjoy. So thank you, Katrina. Good morning, everyone. We are delighted to have you in this conversation today. As Katrina has introduced, our panel discussion is going to be focused around healthcare workers, their mental health issues, as regards to patient safety. So to anchor the discussions, we have three panelists who are healthcare workers. Oh, sorry, by the way, my name is Rita Okonkwo, so I'm going to be moderating these sections alongside with the other three panelists. So to begin, maybe we'll start with Dr. Abiri. Yeah, Dr. Abiri, maybe just to shed more light on the topic and the concept, especially for our audience who may not be very familiar with the concept of patient safety, and all that. This year, the focus of patient safety, it's on healthcare workers, their priorities as regards to patient safety. I mean, why is this important? Why do we have to have this conversation? Can healthcare workers be possibly, at risk in the dedication of their duty? How much of this is a concern, and what are the key things that we need to know with regards to healthcare workers and patient safety? Dr. Abiri.
Thank you very much for the question and for the opportunity. Yes. So, of course, healthcare workers are no gods. We're humans like everyone else. And I often liken the healthcare worker to a mother who takes care of everyone else, but forgets to take care of herself. So I was saying that I often liken healthcare workers to mothers who appear to take care of everyone else but themselves. And of course, I think it's important to look at the concept of work. The fact that work is good for health, but a negative workplace or a negative work environment is detrimental for both physical and mental health. It's also important that we're having this conversation. It's also important that we're having this conversation on workers' safety, especially because as adults, a third of our lives are spent at the workplace. This generation, of course, the 21st century generation, has been described as one that is exposed to so much stress, so much rigor at the workplace. And very often, the 21st century workplace is volatile, uncertain, complex, and ambiguous workplace. And of course, very recently, the fact that it's also a field workplace. I think, you know, this session would not be complete if we didn't remember the current pandemic that is ongoing and the impact that it has had on us as healthcare workers. You know, the unprecedented nature of the current pandemic, the fact that it's a novel virus, the uncertainty of the times that we're in, the exposure to the news, the constant exposure to the news, the fact that the current times that we're in have challenged even the best healthcare systems in the world. How much more our own healthcare systems that we know that many times we often describe as struggling. And it's for that reason that, you know, it's important that we're looking at the mental health of the healthcare worker, especially because even before now, it has often gotten less than the attention that it deserves. Like I said earlier, we often tend to take care of everyone else but ourselves. If you ask the average healthcare worker, when was the last time you did a blood pressure recording or a sugar check, or just decided to take care of your own self, your guess to that response is as good as mine. And of course, in times like this, we also need to start looking at the non-conducive conditions at our workplaces, the physical non-conducive conditions, the poor responses to healthcare workers' demands. As you know, over and again, you have healthcare workers, you know, frequently asking for either a pay raise, all of that many times are not responded to. And of course, the frictions in relationships at the workplace are factors that have continued to impact negatively on the healthcare worker and their mental health. It would be incomplete if I, of course, didn't talk about the fact that even when healthcare workers deserve or need to see another healthcare worker, there's often no desire to get that done. Again, that fact that the healthcare worker takes care of everyone else but themselves. Of course, it's important to also talk about, you know, the important fund victims, which happens to quite a lot of healthcare workers who may be faced with traumatic events that may have happened to their clients or to their patients in the course of treatment, or on an unanticipated adverse patient event, a medical error, or a related trauma that happens to that individual. You know, the health care a lot of times we're able to find that in the course of their work, they may become overwhelmed by emotions, they become by a lot of that, which of course put them at risk of being second victims. In psychiatry, we often refer to that, of course, as compassion fatigue. That comes along with compassion fatigue or the burnout that occurs when, you know, health are in the line of work and of course get affected by issues in the line of work. I think issues such as, you know, workplace bullying and workplace incivility are also extremely important, and this conversation would not be complete without talking about the emotional shock to healthcare workers, especially in their line of work, either from their superiors, either from the people at their own levels, or even from, you know, people who are subordinate to them, or even from clients that we attend to while in the line of our work. I think that it's an important discussion that we're having this morning, since we have decided to look at all of the issues that can affect healthcare workers and of course their safety in their line of work. Thank you very much.
Okay, thank you so much. Thank you so much. Just for our participants, please, if you have questions, if you have comments, please use the question and answer section to let us know what your questions are and let us know what your comments are. We can, draw the attention of the panelists to give response to your question. Thank you again so much. So we move to shed more light on this, with regards to the concept that Dr. Abiri, just mentioned, the second victim. As a quality improvement expert, as somebody who has been on the field supporting quality improvement, how do you think healthcare facilities can get started to provide support for second victims? Nurse Chika?
Okay, sure. I want to say that I think this begins with awareness, right? First, we have to acknowledge that this actually exists. According to a recent study, second victim phenomenon can actually happen up to 43%. And who is vulnerable to this? So I think anyone who earns a certificate in the business of care, a degree or a certificate in the business of care, you automatically have a moral and an ethical obligation to do no harm, right? So we wake up in the morning and we put on our ethical and moral suit to go and care for clients. We met with a bad system, right? What did one of our founding fathers say about a bad system? A bad system will eat a good person every time. So let's talk about awareness. Let's talk about cultures and systems that established this system of awareness. 18 years old Libby Zion died from a medical error at Cornell University. Betsy Leckman, who is a Boston Globe healthcare reporter, dies of chemotherapy overdose at Harvard University. Willie King is a 51-year-old who got their wrong leg amputated in a hospital in Tampa, Florida. Josie King dies of dehydration at 18 months old at Johns Hopkins. Jessica Santini dies after receiving heart and lung transplants at Duke University because they gave her the wrong blood type. So these are systems that actually put structures in place to be aware that the system is not supportive of the people that have come in to care for them. I think first, we first need to recognize that our system can set us up for failure. And that also puts us at risk to become second victims because our intentions are not being met. Secondly, we need to understand why this exists, right? So why do we have the second victim phenomenon? The number one root cause, if you ask me, is a culture of blame. If you work in an organization that has this culture of blame and shame when a medical error is made, so you're going to always produce a lot of second victim. And guess what? If you fire them and your system is still poor, the next good person with a good moral suit and ethical practice, ethical intention comes in and they're going to be eaten up by that bad system. So understanding the root cause and understanding that this is a system thinking approach rather than a blame culture. Most organizations will react to medical error by or patient harm by being malicious. We threaten the care worker, we isolate them, we're just not supportive at all. And again, you may get rid of them, but your system, that poor system, is still in existence. So I think the profound intervention is really that change in culture. There needs to be a paradigm shift from culture of blame to just culture. And that begins with a visionary leader who says, I want this organization, the leader, this starts with the leadership. I want this organization to have a culture of safety. And we're going to prioritize patient safety and prioritize our team safety as well, because they go hand in hand. If you have a culture of safety, it is equivalent to having a team safety, because the team, if they're safe, they are the ones that would uphold that culture of safety. So that leads to a system thinking approach. And it's also an acknowledgement that air is human. So let me call attention to our inherent cultural, and I know I'm threading into a dangerous zone. I'm being brave to do this, but let me call attention to our inherent cultural, I suppose, barrier. We live in Nigeria. We live in a culture that's inherently hierarchical. So we need to flatten that curve. Because if you are an employee and you have a flight or fight response when you see your boss, that is not a culture that is going to set up for safety. Or if you have, if you work in an organization and when you walk in, your staff are not comfortable speaking up and even stopping you, the leader, when we're going into the wrong direction, then you don't have a culture of safety. So these are some of the root causes that could lead to this second victim phenomenon. Let me also talk about prioritizing culture of safety and implementing and executing it. So this is not, hey team, I care about you and I want us to do well. This is you saying, hey team, we are prioritizing culture of safety and it's part of our strategic goal in the organization. Again, starting with the leadership. And it's not just putting it as a conceptual thing, you're measuring it. You have measures of success. So you are telling your team, we value you and we want you to be safe, because if you're safe, our consumers, our customers, our clients are safe. So execution is the next phase, but it's not execution where you just say it, it's execution where it's actually integrated in your strategic plan. So value your team, have a way to measure it. You're committing to their engagement, their safety, their development, their well-being, and you're also establishing markers of success, and of course, resource allocation. I think these are some of the actions one can take to prioritize culture of safety and safety of your team, that thus preventing the second victim phenomenon. Thank you.
Thank you so much, Ms. Chika. I mean, you mentioned very key points. To begin with, your advice to healthcare organization, they should establish a culture or a blame-free culture. Very true, and that a visionary leadership that guarantees open communication, value for team, commitment to safety and development of the team is also very critical. And then also important, you mentioned a system thinking approach to problem solving, as opposed to, look for, or harm, approach it with a system thinking lens. Thank you so much. Let's come back again to you, Dr. Aburu. Dr. Abiri, we want you to shed more light again on a concept you mentioned earlier on when you talked about workplace bullying. Share with us from your experience as a healthcare worker, what are the common predictors of healthcare workers bullying or workplace incivility from your experience that you think people should be aware of? Dr. Abiri, are you with us?
Yes, okay. Yeah, I lost you there at the last second. All right then, well, thank you very much. And I think that to be fair, it would be an interplay of many factors, not just one. The factors or predictive factors would be more of individual factors, environmental factors, and of course, organizational factors. And when I say an interplay, it's because I would say very often you find that it's not one that precedes the other, or one does not occur in isolation as compared with the others. Very often we find that all of these factors are working together to continue to encourage bullying and incivility in the workplace. A number of times, and very often, we find that it's very unconscious. People do not realize that they are, engaging in activities or engaging in activities that are seen to be, to continue to encourage bullying in the workplace. Sometimes not even saying anything about it will continue to encourage bullying to happen. And so there are certain factors which may be individual factors, environmental factors, of course, the environment we live in, and organizational factors that continue to allow bullying to exist and continue to thrive. And so individual factors, of course, would include certain factors such as the personality of the individual. Is the personality of the individual one that is seen as taking the blame or wanting to apologize for everything that happens at every point in time? You'd find that that kind of a personality is seen, of course, in people who have a bit of a dependent personality or an over-anxious or avoidant personality type. And they're likely to be the ones who want to apologize for everything, including something that is not their fault. If you have people who have, self-esteem issues, confidence issues, who feel like that they're not skilled at their job, or who may be overwhelmed by the imposter syndrome, feeling like even when I do something right, it does not exactly, the credit shouldn't come to me, or maybe it was a fluke, maybe I just got it right at some point. So not being sure of yourself as an individual is also a factor, an individual factor that may continue to allow, bullies to thrive without you knowing about it. Age, of course, very often we find that people who are young age, especially when there are issues of, multi-generational challenges in the workplace, depending on the kind of workplace environment that individuals also work. Gender, of course, is a very big deal. Gender, especially in our kind of environment where it's a patriarchal society and more, a lot more effort and a lot more credence is given to the male gender. The level at the work is also a predictive factor, because we often find that people who are at lower cadres are more likely to, suffer from bullying from their senior colleagues. Of course, this is not a fact that is cast in stone, because we've also seen that there have been issues and studies where even people in junior positions have been found to bully people in senior positions, depending on what, the individual factors are. The environmental factor, of course, the biggest, of course, on the table will be the fact that, again, we are a patriarchal society where credence, of course, will often always be given to the male gender. They did it better, or they said it better, and very often the female gender is allowed or, well, perceived to be taking a back seat. Organizational factors, and I like to say this, that as long as it is the culture of an organization, whether it is known to them or known to them that they're actually, encouraging a culture of bullying and incivility is extremely important. Many organizations exist, and when, you try to ask about or try to challenge the status quo, they tell you that, oh, that's how it has been here for a very long time. Very often, we also find that when no one is able to question the status quo, or there are no measures in place to ensure that, bullying or incivility or acts of incivility is checked at any point in time, it continues to thrive. So it may not be seen as an active thing that is done by everyone, but when mom is the word and everyone continues to keep quiet about the injustice or the unfairness that is meted out to any one in the organization who may be suffering from bullying or incivility, this act will continue to thrive. So an organizational culture that drives or in which it thrives the act of bullying and incivility are also, factors that are seen to encourage bullying and incivility in organizations. Thank you.
Okay, thank you so much, Dr. Abiri. You mentioned gender as one of gender, you mentioned patriarchy, and then lastly, you mentioned organizational factors as one of the predictors of workplace instability that is quite common in our workplace. Dr. Zainab, can you shed more light? I mean, as a QI expert, someone who has led a QI team, from what Dr. Abiri said, organizational factors that does not permit the culture of, communication and questioning status quo. And all these has also posed further barriers to underreporting, of workplace incivility, as we have seen in the recent times. So with respect to eliminating these behaviors, workplace incivility and all that, and being mindful of the fact that underreporting still exists and is a major barrier, what's your advice in terms of what are the key considerations if we must get started to establishing a safety culture that is a safety culture that helps to eliminate these very negative behaviors?
Thank you so much, Rita, and welcome everybody. First of all, I think we must recognize that it is going on, and I'll base my submission on my experience from medical school and then residency training. For those in the Nigerian Twitter space, occasionally once in a year, this thing comes up. One medical student posts, what was your most embarrassing moment as a medical student? And then you see a lot of incivility in the comments from the senior colleagues. For example, there was one where, okay, let me give my own example. In my senior residency years, I was pregnant, and then I was presenting at a morbidity mortality meeting. And then I apparently misunderstood the question of the consultant. And then when I answered, he said, oh, I didn't expect you to answer correctly. I mean, now residency is so easy. Residents can have sex and get pregnant. Now that is incivility, clear 100%. So we must recognize that it is happening. And then when we recognize that it is happening, then we can start to do something about it. So, and unfortunately, it is like a vicious cycle. I was a victim, and I admit I was a perpetrator, an unconscious perpetrator, until I decided, when I found out I was an unconscious perpetrator, I made up my mind to break the vicious cycle. So one, we must admit that it is happening, and two, we must break the vicious cycle. So how do we go about breaking the vicious cycle? First of all, I recently advocated to the head of a prominent teaching institution, teaching hospital, that I think it would be a good idea to teach resilience, emotional intelligence at undergraduate and postgraduate levels, so that you have an idea of what you're doing, what the bearing is on your junior ones, and when you do that, we can hopefully start to produce people who are sensitive to the feeling of others. And of course, again, we must teach resilience to a certain extent. One of the previous panelists mentioned something about the personality type. There's some who just have this tendency to take blame. And there is no year that we do not hear of health workers committing suicide or having healthcare issues or having psychological issues. If we're able to build resilience, we're able to teach them emotional intelligence, then I think we have started. And then we must have an avenue for reporting and an avenue for them to seek redress. Thank you.
Thank you so much. Yeah, thank you so much, Dr. Zainab. You mentioned that admitting first that this happens and committing to breaking the vicious cycle. And you mentioned also incorporating resilience teaching and emotional intelligence as part of medical education, which is very key to train more healthcare workers who are more sensitive to the needs of others, and also having a system or a culture of respect and dignity for staff. Some of the entry points for organizations and to get started to eliminating bullying and workplace and incivility. Thank you so much. And so let's come back again to you, Dr. Zainab. You've mentioned these key points, and also, so what role do you see for interprofessional teams to support this safety culture? Earlier in the conversation, Dr. Abiri mentioned that CADAL, it's one of the things, having, nurses bully doctors, doctor bully nurses, doctors bully this and all that. So what role do you see for interprofessional teams, to support establishing a safety culture for our healthcare institutions? Dr.
Thank
Zainab.
you again, Rita. Yeah, thank you. First of all, let me anchor the beginning of my submission to one of the very important things Rita mentioned about education. First of all, do we know that we know the importance, and do we know how we should set up a safety culture? A prominent thought leader once said that organizational culture eats strategy for breakfast, lunch, and dinner. So whatever you put in place, whatever strategy you put in place, if your organizational culture does not support safety, it's not going to work. It's been proven over and over and over. So we must have a safety structure in place. And for us to have one in place, we must be educated on what it is and how to set it up. Please do not try to reinvent the wheel. There's so many QR mentors out there. There's a lot of resources out there, and a lot of them are free. If your organization doesn't have one, start to find out how can you do one. For those of you in the Nigerian space, I'll be giving a lecture soon, and I'll be making reference to how we could possibly set up a safety culture. And then again, ask yourself, if there's one in your institution, are you happy with it? Do you know what is going on there? And then ask yourself, how can I be part of it? Then on the general issues of a safety culture, every healthcare specialty, subspecialty, has some basic training on safety as related to their profession. For example, the pharmacists have medication safety. Here we are, and globally, there's something called patient safety. You should ask, how can I get involved in this? Because it is important we all get involved, because whatever we provide is what we're going to get when, not if, when we fall ill, because we'll all fall ill one day, and whatever safety structure is on ground is what we're going to get. Thank you.
Okay, thank you so much, Dr. Zainab. Let's go back to Nurse Chika. Now, Dr. Zainab has really set the tone, that organizations or healthcare organizations needs to establish a safety program. And we have seen that, very clearly in some of the developed countries and, established healthcare facilities, where they have an established QI program or a patient safety program that seeks to improve the safety culture of the organization, and then also provide support and care for victims of harm, like second victims. And but then also we've seen that a lot of facilities, there's this drawback for some healthcare facilities, not wanting to get started to providing this needed support, especially for second victims. Nurse Chika, from your experience, what do you think are some of the possible reasons why healthcare facilities, especially in Africa here and Nigeria, are withdrawing from providing the needed support that second victims would require? And then what do you think could be some possible incentive or benefits to motivate healthcare organizations to actually get started to establishing a safety program for their facility? One of the things that we want to see after this year's celebration of World Safety Day is that more healthcare organizations are reaching out to want to establish a safety program. Yeah.
Thank you so much, Rita, for that question, and it's an important one. My co-panelists, they sort of touched on this. It's about awareness. I think if you ask me, the fundamental reasons why, one of the fundamental reasons why most organizations are not embarking on this safety journey is really just lack of understanding the importance of it, understanding the impact of not having a safety culture on the organization, and understanding the poor outcome financially even, and just patient and consumers, the impact on consumers. So I think the most important one is understanding the impact of this and its consequences, right? So if you don't illuminate the problem, if the problem is not showing, then we're not going to do anything about it. So you asked, are there possible benefits for healthcare facilities if they consider caring for second victims? Absolutely. If you have a safety program, if you have a culture of safety, it speaks volume about an organization who recognizes that system may not be set up for success, and no matter how many people you have route through the system, that the same outcome is, you're going to continue to produce the same outcome, and that is costly. Okay, if let's put patient lives and consumers' life and workers' safety to the side. Let's talk about cost, right? So you are constantly having turnover, you're constantly having bad outcome, you're ruining your reputation publicly, right? So people are saying, I went to that hospital and I died and this happened. So there are a lot of word of mouth. So if you don't really know all of this other impact, at least the financial component and the impact it will have directly on the organization is there. So I think if you embark on the journey of patient safety, or culture of safety, for both your team and patients and clients, you will save life, you will decrease costs, you will decrease turnover, you will engage your team. And I think, to me, the overall results are this: overall, a safe environment for your patients and consumers and customer. Overall, staff safety, you remove barriers to error reporting, which is fundamental. If people aren't bringing forth the barriers that they're encountering, then there's no way that we can make improvements. We cannot improve what we don't measure. So we need a structure that is actually allowing us to sort of shine light to our barriers where we're encountering, and you get engaged workforce. So no one could really ever hire, no one could know it all, right? So when you employ your team, this is speaking to the leaders, when you have a team, you are hiring them for their expertise, their skills. You want to lay a foundation that actually forum that allow them to come forth and be creative and come up with the idea. If you don't intentionally establish such structures, then you're going to lose out. They will show up for work, you'll pay them, and they'll go home. You are losing out because you're not capitalizing on what they brought forth and why you hired them. And above all, you will establish a high reliable organization. That is all about high reliability, and it's really quite dependent on the team that you produce. So I think investment in your team, again, produces a culture of safety for not just your clients, but for also those that you've employed. So thank you for that important question.
Okay, thank you so much, Nurse Chika. I mean, one thing I take from what you have just said is that it's really economically viable to invest in a patient safety program for the healthcare organizations. You save a lot of costs from loss of your healthcare workers, costs from not even maximizing the full potentials that your healthcare workers bring in supporting your organization. So, I mean, if there's any incentive, I think that's enough incentive for healthcare organizations to carry on this, forward. Thank you so much, Dr. Chika. I mean, Dr. Zainab, Dr. Chika mentioned something, I mean, awareness that
Yes.
one of the drawbacks, that one of the drawback is awareness, that the awareness for a lot of healthcare organizations that there is something that they can do to improve their system. It's a major challenge why some of these healthcare organizations don't have established QI program. I know you have been on the forefront of QI at a facility, you have led a QI team. What do you think? I mean, what ways do you think that we can create that awareness? Because we want to carry on this discussion forward. We want more established QI programs and safety programs to emerge from Africa. So, I mean, what are the opportunities of raising this awareness? Dr. Zainab.
Okay. Thank you again, Rita. A lot of that is contained in my presentation in the next session of how to set up a quality improvement program. But again, the first thing will be if you have an existing one, you learn how to strengthen it. But let's assume you do not have one. How do you get one started? There are a lot of organizations who have a few here and there, and you could get one. So if I might borrow from our experience, how we got started in the first place, I leveraged on colleagues and friends in the diaspora who've worked in the quality improvement space. And I spoke with them that there's a need for us to set up a quality improvement and patient safety structure here. And they went to work, they rallied around us. I'm no longer in office. And today I give them a lot of credit for holding my hand throughout the period I was in office until today that I'm no longer in office. We're still working with them. So leverage on the power of the diaspora if you have that. If you do not have that, find out what are the organizations that are existing that have a structured quality improvement program. There are some that are for profit, and there are some that are not for profit, and you can easily find them on the internet. So find out from them, and then I will advise that you also team up with others who are interested in starting one, so that you have like a small community of practice, and you can give each other strength as you grow on. And then I would suggest that no matter how little your win is, make sure you celebrate it, put it out. Does your hospital have a newsletter? Make sure you put your wins and even sometimes your challenges in your hospital newsletter. Put it on your hospital's website. Are you on social media? Social media is the in thing now. Put it on social media. Let everybody know where you're going. And you'll be amazed how many people will reach out. For example, Tai, who put all of this, who was one of the brains behind putting all of this together. We met on social media. I was putting up one of our successes, and we've been in tune on quality improvement and patient safety since then. So please, there are a lot of opportunities, and I don't think we should let them go. Thank you.
Thank you so much, Dr. Zainab. Dr. Chika, Nurse Chika. Okay, so back to you again. We have a lot of nurses who are part of the audience. Yeah, it's interesting to see, you know, how passionate you are about quality and safety, how much you have done, how much you've invested in yourself to really get yourself to where you are today. Maybe some of the motivational tips, could encourage some nurses here. I mean, I've been supporting QI in facility for the last 10 years. And one of the challenge we had is to really get people to see beyond just providing care, bedside care for patients, to actually going beyond that, to look at the process of care and establishing systems of improvement. I mean, it would be interesting to, you know, for you to shed some light to some, to the nurses, I mean, who are here as part of our audience, as to, I mean, how you got started, and then how nursing is beyond just providing care, and also looking at systems. Nurse Chika.
Thank you so much, and thank you for giving our nurses the audience to talk about this. So, how I got started really was it's just really my experience from being at the bedside. You know, there's this notion that when you come to work, you deliver care, your best care to the one client or two clients or however clients you have. And as I progressed in my role and my experiences in nursing, I realized that a lot of things, there's a lot, nurses could speak to this. When there's something goes wrong, there's nurses should do this. And we're often not at the table to make these decisions, right? We're not partners with our leaders, we're not partners with our physician, but we're fighting in the same battlefield. So, and when you truly think about this, and sorry for my physician friends that are on board, but the truth is, physicians come in and they see the clients and they leave, and who stays with the patient, right? Truly, people are in the hospital for nursing care. Yes, physicians round and they leave. Who is constantly there 24/7? The nurses. So we are a critical component to this patient safety journey. We have to play a part. Our voices need to be heard because we see it all. And who brings up matter? Who raises concern? Whose critical thinking is at play when we're looking at our patient safety? Nurses as well. So we are equal partner in this journey. And you know, the thing about patient safety and quality improvement is, yes, we all have our clinical background with physician, nurse, speech therapist, psychiatric. We come in with that. But when it comes to patient safety, we are at the same level because we're all learning this, we're all growing together, and we have a shared aim of improving patient safety, and we can all throw in our point of view. So I am calling on nurses to come on this journey. We're not enough. We need to be part of this because we are really, really critical to the success of this patient journey, our patient safety of patient culture of safety journey. I hope I've answered that question as much as possible.
Thank you so much, Nurse Chika. I hope the nurses here are motivated, and that in the next community of practice meeting would have more participation and more people signing up to really get the knowledge on really how to get started. ISQua has a lot of certificate course and fellowship program, you know, that can support you with developing the needed skill and competence to get started. Thank you so much, Nurse Chika. We have a question here. I will throw this to all the panelists to shed the light into it. Maybe we could start from Dr. Zainab, who is very much active still at the forefront. I mean, a question here from Mohammed, you know, saying, what is the safe time to spend standing for healthcare workers? Because there are many complaints of back pain, waist pain from prolonged exposure, especially operating theaters, personnel and accident and emergency personnel. Okay, personnel, I guess. Yeah.
All right.
So any of the panelists can take in and shed light to on that.
All right. So thank you, Mohammed, for your question. I don't think there's a hard and fast rule for how long you can stand. It basically depends on your personality, your training. But I think it's very important that we emphasize that whilst you have a job to do, there is also you. If you're not healthy, you cannot do a good job. And your patient is not safe if you cannot do a good job. So my suggestion for every member of staff in the hospital and every stakeholder, including the patients, is you must be healthy. And one of the ways to be healthy is by regular exercise. You do not need to have a lot of expensive equipment to be able to keep fit. There's so many things that you can do to keep yourself healthy. A healthy walk 30 minutes every day is a good one, and then eat healthy. That would help you. And at the slightest moment you feel something isn't right, please be sure to consult an expert. Most healthcare workers, yours truly included, when I have a health problem, it takes me time to seek help. I recently had a clavicular fracture, and until the pain got very bad, I did not go to see my orthopod. So please, if you are not healthy, you cannot do a good job. So my suggestion to everybody is stay healthy, keep healthy for you to be healthy and to do a good work for your patients.
Okay, thank you, Dr. Zainab. Any of the panelists want to respond again to that? Good to go.
Well, I mean, if I was just going to lend my voice to that, I'd write on what Dr. Zainab had previously said about how you need to individualize yourself as a person, whether or not there are even strict rules as to how long to stand or when to stand. So for instance, if you had a physical health condition that would not let you stand for that long, of course, you would need to vary it per time. But like she's also identified, one of the most selfless things that we can do for ourselves sometimes is to be selfish. You need to learn to take care of yourself first, because we can't serve from an empty vessel. So self-care is extremely important. We should be kind to others, but of course, you need to be kind to yourself first of all. Put on your mask first. If you are not in a good state of mind, either physically or mentally, you can't tend to anyone else. So please, by all means, pay attention to your body, listen to your body, rest when needed, and take good care of yourself at all times. Thank you.
And just adding to what my co-panelists have just said, I think also paying attention to body mechanics. That's something we actually learn coming into the workforce. Understanding we are lifting patients that are bigger than us. We're turning patients, maybe even a nursing focused idea. We're turning patients that are bigger than us. Dr. Zainab, I'm sure when you're in surgery, you may have to turn and, there are body mechanics that we should utilize to really make sure that we are protecting our backs. And again, talking about organizational structure, we should teach our workforce of how to protect themselves. That should be a competency coming into any organization, and you paying attention to how to protect yourself. I know a lot of nurses that have gone out of the career because of injured back, injured this, or injured some kind of injury. And also, I'm glad Dr. Abiri is here. We've had a lot of workforce that are injured by the clients because of some kind of psychological disorder. Paying attention to understanding when there's an escalation going on with a patient, and how do you de-escalate that event so that you don't get harmed and the patient doesn't get harmed. So there are a lot of competency that is actually needed as healthcare workers to go into the workforce, both physical, psychological, all of it. And again, like they said, take care of yourself. Understand when you're stressed, understand when you're exhibiting signs of stress, and take care of you physically and mentally, because you cannot love others if you don't love yourself. Thank you.
Thank you so much, Nurse Chika. I mean, you echoed it all. The panelists have said it all. The change begins with you. The entry points to begin for healthcare workers' safety starts from you, the healthcare workers. You determining what your limits are, you setting the boundaries, you taking care of yourself, building resilience, building your emotional intelligence, and putting up your coping mechanism when the stress comes. Because yes, the stress will come like we have right now in the pandemic. Thank you so much. My next question would go to Dr. Abiri. In terms of care for the second victim, I mean, as a behavioral therapist, how much of care do they need? For how long do we need to provide this care and support? I'm talking from the side of, I mean, being a patient sometimes, because it could be a thing of worry to the patient, they want to know that their healthcare worker is mentally, okay, and to provide the needed care. So with regards to patient safety, as in the patient, how much care do we need to provide for second victims? And do we need to excuse them from being at the front line for a period of time? I mean, I think that advice would be critical to healthcare organizations that would want to establish a safety program to care and support second victims. Thank you.
All right. Well, thank you again for the question. And I think then again, we would have to go back to, finding out what exactly the organizational culture is about. If, if healthcare workers' safety and healthcare workers, health is extremely paramount at the workplace, then it does not come into question at every point in time when you find that someone needs care, especially as being a second victim themselves. So when individuals, so for instance, I was having this conversation with my team last week, and we were talking about how, it is that we care for everyone else, and then who cares for those of us that are in-house? And we had said that, there were ways that we could look inwards. So for instance, you could, set up, for instance, screening questionnaires that you give to your staff per time to find out what exactly it is their difficulties are, what their current challenges are. We decided that we should continue to encourage an open door. We decided that we should continue to encourage an open door policy where people can come in and discuss whatever problems there are. Very often we find that if things don't become critical, we don't discuss it. If things don't become critical, we don't attend to it. So if the organization, for instance, has it in place that for everyone who is going through a difficult time, and that's where, support, encouragement to seek help, especially when you as a healthcare worker is not doing well, either in your physical or mental health, is extremely important. We must be the ones to, first of all, be able to pick up, signs and symptoms in ourselves. We must know our bodies. We must be willing to listen to our bodies. And of course, we shouldn't wait until distressing symptoms start to happen to all of us. Of course, we all face stress. We all face the issues. We face the traumas. We experience some of the things that our clients do experience. And when these things do happen, of course, there are normal responses, which can be, of course, undue irritability, confusion, tension, which will last for a few days. But after a few days, you're able to get back on your feet. But when you find that, biological functions of sleep, appetite, libido are suffering, or you're beginning to have affectation in issues regarding your mood, your anxiety levels, your perception, or even your behavior, it may then, begin to show that we're moving from a normal response to an abnormal response. Of course, it's also extremely important for the individual to know themselves and have a high index of suspicion. Usually when we're faced with stress or exposed to, stressful life events, we find that we can do things like talking to somebody, you can seek professional help, you can read about what it is that you're going through. But if at any point in time you're beginning to find that you're using maladaptive coping mechanisms such as eating excessively, spending excessively, engaging in self-harm, engaging in aggressive behavior, you find that you're unduly irritable, you're using much more alcohol, or you're beginning to cope with even the use of prescription medication just to escape from the harsh reality that you found yourself. It's important that you as an individual, first of all, is able to pick up these signs by yourself. If you can't pick up these signs by yourself, it's the reason why the organization also must have a culture of safety, and of course, must encourage that people look out for each other. If you look out for each other, you're able to tell how the other person is on a usual day, and you're able to tell when, of course, they're faced with a lot of stress. There's also the place, of course, for supervisors who delegate duties to people to understand that sometimes the emotional labor associated with a certain kind of work is more as compared with others. It's also important for supervisors to be taught how to look out for signs of distress in junior workers. But of course, at the end of it all, if the organization is one that is responsive to its staff, that is willing to, ensure that the staff is well taken care by all means, even every once in a while, we can say that, this staff should take days off. It's the reason why we should also say that we must insist that people should go on their leave. Don't always say you want to monetize your leave. We all need rest. And it's not until we become the patients that we, realize that we should stop. We should stop to take care of ourselves, especially when you can see the subtle signs. A few weeks ago, I forgot 2 meetings I was supposed to be at, and I had to tell them at work, guys, it's stress. I need to rest. It's when I get burnt out, overwhelmed, that I feel like this. And honestly, it didn't have to get to that. We also, of course, need to educate ourselves and be able to identify and recognize the things that trigger us off as stress. Stress is a normal response, of course, to any threat. But when we start to feel distressed in such a way that we cannot function maximally in our personal, occupational, or social environment, it's definitely time for a checkup. Thank you.
Thank you so much, Dr. Abiri. I take something from what you've said. It has to be on a case-by-case basis, and the patient, that's the healthcare worker who is affected or who is traumatized, has a lot of role to play in communicating how much support and how much help that they need. And organizations should have a culture of really providing that support to as much as it's possible. And healthcare workers should be strongly encouraged to take their leave. I think that's a big take home for healthcare workers, and to all of us here to take our leave and really rest. It's a leave to rest. Yeah, oftentimes we take our leave to get into another activity and really not rest. So I think that's an action point for every healthcare worker here. Please take your leave and truly rest. So we have a question here from Chineye Okonkwo. She's saying, in the event that, okay, I'm adding this to her question. Her question is, what can you do as an individual practitioner when your facility is not providing the basic safety for your practice? I want to add on to what she has asked. In the event that as an individual, as a healthcare worker, you have done the best that you can in supporting yourself, but then there are some safety, basic safety, that you expect or you require from your organization, maybe like safety devices and all that, protective devices. What can you do as an individual practitioner when your facility is not providing that basic safety for your practice? Dr. Zainab, maybe you want to start by shedding light, and our other panelists can also please jump in and share your thoughts as to what you think we can do in the settings that we are here in Africa and in Nigeria also, if that's where your experience is. Thank you.
Thank you, Rita, and thank you for the question. I'll start by the popular quote, ask not what your country can do for you, but what you can do for your country. In this case, particularly in Africa, where we have a huge funding gap in health, let us start to look inward, particularly to the ones that are very important to us. What happens when, what do you think of 3-4 people, let's say it's the nurses who are mostly complaining about issues of safety in the workplace. Why don't you get together, your association, form a support group for those who you think have been traumatized, whether psychologically or physically, and then expand it to include other healthcare workers. And then before you know what's happening, by the time you're able to showcase your successes to the administration, they will adopt it and make it an institutional thing. So think about this is a call to action. Then again, there's this model of saying that in leadership that says that you should be able to rally the power of community again when something up. So for example, now, when I was doing residency, there was this very popular thing that it was happening when I started, and at least I know it happened after I started. I don't know whether it has stopped now. The pathologists who carry out autopsies there's this culture, because our culture does not really understand doing autopsy, particularly when a patient dies suddenly, a patient you're not expecting to die. And then the relations want the corpses back at the earliest, particularly for the Muslims who want to bury early. And the institution where I train has the rule that such patients must have an autopsy. Usually the pathologist who has to do the autopsy that they were not expecting, so this is like, in quotes, an emergency autopsy. Such pathologists, I don't think 6 months pass by before you get relations of the dead patient assaulting the pathologist. And it was happening when I started. It happened for some time after I started. So what would happen if the pathologists got together and say there should be a separate exit created, a separate entry created for the pathologist and the patient relation, so that there's even no way they can meet you, so that you go, you do the autopsy. Of course, there's a need to educate them on why this is important, so that they understand that this has to be done. And then put a further barrier to assaulting pathologists. Can you barricade the entrance through which the pathologist is going in, and it should be separate from where the patient can come in, such that no matter how enraged they are, even after you've educated them, they cannot have access to assault the pathologist who is just doing his work and working on others. So it's important that we get together and see what we can do for ourselves if the system isn't doing anything for us. Thank you, Rita.
Rita, thank you. Okay.
Sorry, let me ask Dr. Awadzina, you're absolutely right. A friend of mine once taught me that one man with courage is the majority. And when you have that courage, it's because you're driven by purpose. If you feel, and there's this assumption that leaders know it all, that your leaders, they should know what to do. And that is simply not true. So if you are experiencing an issue from your department and you're assuming that your leaders should know, what if they don't? What if it's not in their radar? What if that's not what they're thinking about? What if you can actually influence their thought? And also, how do you present it? How do you come up to say it? Do you come up angrily and just feel like it's a personal attack? Or do you come from a global point of view to say, hey, this is a concern? If you have data to support what you're feeling, bring data. If you have facts, if you have other organizations that face the same problem and they've proven that this method would work, do some research, bring it up and present it to your leader. But the assumption that they know they should do it it leaves room for a lot of mistrust and poor judgment. So I say, if you feel this and you have the courage to come up with it, do some research, back it up with some data, some facts, and present it to your leader and see what happens from there. Thank you.
Thank you so much, Nurse Chika. Just to add to the conversation, from my experience being on the field and supporting QI, I would add this. Oftentimes, healthcare workers complain of, oh, this is not available, we don't have the support and all that. One of the major gains of QI, what QI really brings, is really helping to maximize opportunities that are available within your reach. So if the team can come together and really understand, okay, what's the problem that we face? What can we do within our limits? You would see that there are so many opportunities of things that you can do just by rearranging your care processes, strengthening your processes, maximizing the time of healthcare workers. You will see, to a great extent, you would be able to provide some of the support that you need. This is not saying that there's no role for that above facility level support or interventions from the healthcare facility leadership and management structure and all that. But then this is also saying maximizing internal opportunities, looking out for loose ends. Where are the holes that we can plug? There are opportunities, and this is really the bedrock of QI. Trying to, strengthen the processes at the very service delivery point. That could be the first entry point. Yeah, but also there is a strong need for management of healthcare facilities to have policies in place, to have plans to support healthcare facilities. We strongly also agree to that, so that the healthcare facilities, the healthcare workers are not overwhelmed in trying to manage what they have. Thank you so much for that conversation. Yeah. So I think our time is almost up. Do we still have any questions? Okay, we have one question from our participant who is asking if we have to set up a safety program or a program for second victim at our facility, who should lead that? I would recommend, this is me from my experience being on the field here in Nigeria, I would recommend somebody who is very enthusiastic about change, because you need somebody who is motivated enough to push through. it takes a lot of commitment to get things done for QI. And then I would also recommend somebody who at least it's a bit on a high level, because you need leadership for QI. Somebody who is also able to convene a meeting, you know, based on setting, you know, power or cadal. So leadership and motivation is a strong consideration in terms of looking out for who should head the team. I would not particularly say it must be a nurse, it must be a doctor, or it must be a pharmacist. From my experience, these are two key considerations for an excellent leader. But I think also from the RISE program, Katrina shared something. Please, participants, I encourage everyone to go and read about the RISE program in Hopkins, you know, headed by Dr. Abadwu. It's a fantastic program if you really want to see a typical case scenario on how to set up a patient safety program to support second victim. The Hopkins experience, the RISE program, it's a program that you want to see, you know, their tools, their resources, how they got started, the kind of support that they provided. I'm sure also in their publications, I mean, they would mention the cadals of persons who work. So it's a teamwork per se, but then you need a leader. So if any of the panelists have any other contributions to that question, please, you have the floor. Thank you.
Rita, I will just add this. I completely agree with you. You do need that leadership support. You need someone who is enthusiastic. I also think you need someone who has also been a second victim. I've been a second victim, and I know what it feels like. I know the just going through the phases of from just the action to recovery. I know what it feels like. So I think it's important. And, you know, just talking about what it felt like not to be supported. And that is even more motivation to put up structure that will support further future second victims. So I think I agree with you, but I will also add that if you've been a second victim, jump on board, because your input will be valuable to that process, to the structure of that. Thank you.
Okay. So thank you, everyone. Thank you, everyone. So the conversation is still on. We are just ending, or we are signing out from the panel section, and we'll continue on the conversation on the next agenda. Thank you so much, panelists.
Thank you.
Thank you.
So, Katrina.
Hi, Rita.
Yeah, okay.
Can you see me? Yeah,
yes,
yeah.
you can.
There I am. Yeah, so next on the agenda, I think we're going to be hearing from Zainab. So she's going to discuss opportunities surrounding quality and safety improvement and how to get started. And just before we go there, you might have noticed that a poll was set up, and I think all of you, or almost all of you, have actually answered the questions on that. So it might be interesting just to have a look at what the results are. So we asked you whereabouts in the world you're joining us from today. 65% of you are in Nigeria. 18% are outside Nigeria, but in the African continent. And there are 17% of people from outside of the African continent. So I'm actually a bit surprised. I thought there'd be more from Nigeria, just because of the way we marketed and everything. But that's brilliant. That's brilliant. In which setting do you work or practice? So 67% of you are working in a hospital or clinical setting. 29% of you are in working in healthcare, but not in a clinical setting. And 4% of you are in a non-healthcare setting, which is also great to see that kind of variation. And then I think an important question was, who do you think the second victim in patient safety refers to? So really, most people actually know about this concept already. So 79% of you said that it is, and correctly, that it is healthcare workers caring for the patient who are also traumatized by the adverse events. And then we had 14% who originally thought it would be referring to relatives of patients affected by adverse events. And actually, that is a term that's used in legal, in the legal world. Second victims would also be, in the legal term, people who witnessed or are close relatives to somebody who suffered. So I can understand why that was. Then then now this is kind of shows the situation at the moment. So have you ever experienced harm yourself or emotional stress as a result of caring for a patient before? So 79% of you have said yes to that, which is huge, really. You know, that's 4 in 5 people really that have experienced emotional stress. So 4 out of 5 of you are second victims here today. That's really interesting. And also 10% of you aren't really sure about that. If you're not sure, then you probably are a second victim, I would say. And then finally, the last question was, do you have a formal functional team or unit in your place of work that you can relate to, that you can go to in the case of emotional stress related to your work? And only 33% of you actually do have that. So that's really massive. There's a massive area there that needs to be addressed in a lot of places. 21% of you aren't even sure. So that's another issue there of communication. Maybe these places do have somewhere for you to go, but they're not communicating that properly to the staff. So it's great insights, and so thanks for taking the time to fill out those few questions. It's really good to see who our audience is, and I can see by this that you're very much the right audience to be here if 4 out of 5 of you are second victims. So thank you again. And I think now we're going to move over to just to Dr. Zainab, who's going to, as I said before, is going to discuss the opportunities surrounding quality and safety improvement and how to get started. And just before that, very quickly, I just wanted to let you know, as a lot of you are in Nigeria today, we do have an ISQua specialist certificate. It's an introduction to quality improvement and patient safety. This is normally between €125 and 350, depending on what kind of country you're based in. But for people in Nigeria, we have a very special rate of €75. So it's a big discount. And if anybody's interested in that, they can either contact myself, and I'll send your emails onto the relevant people. Otherwise, I'll have it in the email tomorrow with the recording, so everyone will get the recording of this. I'll also have some more information about that. All right, so thank you, and we'll hand over to Dr. Zainab now. Thank you.
Thank you very much, Katrina. So, good morning again. This is Zainab Yunusa-Kaltungo from Federal Teaching Hospital, Gombe, Nigeria. I'll be taking us through how to get started in the quality improvement and patient safety project. I have nothing to declare except that if alone. So there we are in the map of Nigeria, in a country where there's no national quality of the map. At the time we started our journey, we're about 20 years established. We had about 1,800 staff, and a lot of our patients come from the 200-kilometer radius. You have to travel to get to another tertiary healthcare institution, about 3.5 million target population. So at the time we started our journey, there were a lot of problems that were begging to be improvement and patient safety problems. And I must say, again, we had a lot of successes, at the same time, a lot of challenges. But I'll be telling you one particular one. So as a surgeon, and then at the head of clinical services in the hospital, the nursing team in the theater were always complaining about how surgical teams would make a very long elective list and then maybe do just about 50% of the cases on the list. And this was happening almost every day. And it was a problem for them. So the patient safety concerns, mind you, some of these patients have to travel 200 kilometers or more to come to access healthcare. Some of them had been on the list for more than a year before they could get, before it was their turn to get operated on. And this is a healthcare system in which a lot of the spending is out of pocket. So imagine that they have to travel they have to travel sometimes to the relation. And then, of course, the nurses could not properly deploy manpower because they have to prepare for cases that they might end up not taking. And it was not a very pleasant situation. So what was our theory on how to improve? We thought, what if we, without calling anybody out, what if we let the surgical teams know that we're watching you without actually saying anything? So that was our theory. So we formed a plan with a multidisciplinary patient safety team that we set up in the course of our quality improvement journey. So we went to our old data so that we have something to compare with, and then we started to collect new data. So initially at the beginning, we did not let anyone know that we're collecting data, tracking the frequency of surgical cancellations. And then we also set up a clinical governance forum where we discussed avoidable than our successes and challenges in the quality improvement journey. And at one of such meetings, there was a big reveal. So according to Odioemene, in God we trust, all others must bring data, right? So here is our data. So 2016, we're not tracking, and then January 2017, we started to track. And then around April was when we did the big reveal at the clinical governance meeting. Clinical governance meeting, usually we have like 70, 80 people attending, and everybody attends, the medical director at the helm of affairs, right down to the cleaning staff. It's usually a meeting that is packed full. Well, we didn't name names, and then we projected our findings, PowerPoint presentation, so specialty booked so number of cases between January and April, canceled so. We didn't name names, and the moment we did that, just take a look at this run chart. Look at the total number of cases that were done in that period. So permit me quotes from the same book that said, we thrive in environments that respect us, feel safe to contribute, and feel safe to challenge the status quo. If we can't do these things, if it's emotionally expensive, fear shuts us down. We're not happy, we're not reaching our potential. But when the environment nurtures psychological safety, there's an explosion of confidence, engagement, and performance. Ask yourself if you feel included, safe to learn, safe to contribute, and safe to challenge the status quo. Finally, ask yourself if you're creating an environment where others can do these 4 things. In the process, look around you and see others with respect and fresh amazement. Find deeper communion in your relationships and more happiness and satisfaction in your life. So now in the Nigeria Quality Improvement and Call to Action. As I mentioned earlier, every person, whether you're a health worker or not, has a stake in this. Because as I said again earlier, whatever has been a lesson from the pandemic, it is that what the quality that's available in the system is all you ever get when you fall ill, not if, because everybody will eventually be a patient one day. Governance guidelines and supporting policies, again, another very short story to illustrate that. So as part of our quality improvement and patient safety journey, we thought it would be nice for us to have documented protocols. So we called on the various specialties. Let's start with you documenting the protocol for your 10 commonest cases. And some specialties were beginning to document theirs, and they were making submissions to my office. And I made the fatal mistake of asking a senior colleague, sir, I've seen submissions from several departments, but I haven't seen any. Is there any federal government policy that says I must work with protocols and guidelines? That was the last time any other department submitted any protocol and guideline after that. And if there's any government stakeholder listening today, we need to rally and get some policies out. They don't need to be mandatory ones, but at least let there be something so that everybody who is working just based on the passion has at least some framework to work in. I remember last year when I made a similar presentation at the Association of Nigerian Physicians in the Americas, and a very senior official from the Federal Ministry of Health said, oh, nice presentation, but I think you should take that presentation to the committee of CMDs and see whether they are adopted. That means they're not even aware that it is their policy, it is their duty to make policies to support quality improvement and patient safety. Silo disruption is another call for action. I was pleasantly surprised when my team and I were organizing the National Patient Safety Conference, to find that there has been a lot of work on quality improvements and patient safety in Nigeria. But I was dismayed again find out that we're all working in silos. We didn't know each other. We must come together. We must do it because really, we're really stronger together. So this is a call to action for us to form a Nigeria community of practice for quality improvement and patient safety. Stakeholder inclusion and education, I can now overemphasize. Katrina already talked about the discounted courses, and I must say a huge thank you to ISQua for making these courses available to us at discounted rates, because almost everybody who's taking that course is because we've been funding from our own pockets, and we're working based on passion. So the more affordable it is, the more people will take it. And I'm certainly coming back to take a fellowship course, ISQua course. So before I close, I must recognize our quality improvement mentors, our heroes, who held my 2 years out of office, and they're still pushing me along on the quality improvement and patient safety journey. Most of them are in the diaspora. They made time out today to be part of this webinar. And there's no way you can write the history of a structured quality improvement program in a government-owned hospital without mentioning their names. They've been great. They continue to be great. And this is a shout out to you, my team. Thank you very much. Thank you. That's the end of my presentation.